Alright, let's talk about ABG. ABG is a blood test that measures the concentration of oxygen, carbon dioxide and bicarb in the blood. ABG is more accurate than VBG. VBG is not accurate because you cannot see whether it is compensated or not. But there's one case where we take VBG in dengue patients because they have bleeding tendency. These are the normal values. First, pH 7.35 to 7.45, PaO2 80 to 100, PaCO2 35 to 45, bicarb 22 to 26, base excess -2 to -2 to +2, and SpO2 or SaO2 keep it more than 95. For COPD, keep it 88 to 92 because the CO2 is needed for hypoxic drive. Step 1 of reading ABG, we determine whether there's hypoxemia or not. The PaO2 of less than 60 is hypoxemic. Level of hypoxemia, severe if less than 40, moderate if less than 60, and mild if less than 80. Step 2, we determine whether it is acidosis or alkalosis. Step 3, we determine whether it is respiratory or metabolic. Step 4, we determine whether it is compensated or decompensated. Respiratory compensation is quick. Metabolic compensation is slow. Compensation is not usually complete. Patient never overcompensate. Metabolic acidosis, compensatory response formula dia, CO2 equals to in bracket 1.5 times bicarb in close bracket plus 8 and then plus minus 2. Metabolic alkalosis formula dia, carbon dioxide equals to in bracket 0.9 times bicarb close bracket plus 9. Respiratory acidosis formula dia, bicarb equals to 0.35 times carbon dioxide. Respiratory alkalosis formula dia, bicarb equals to 0.5 times carbon dioxide. Okay. Step 5, we look at the high or normal anion gap. Anion gap normal 10 to 18. Anion gap only for metabolic acidosis. If it is high anion gap, there are many causes such as DKA, renal failure, lactic acidosis, poisoning, salicylate or ethylene glycol. If it is normal anion gap, metabolic acidosis can be caused by chronic diarrhea, ileostomy, Addison's disease, pancreatic fistula, and renal tubular acidosis. Step number 6, we also look at the base excess. If base excess is less than -2, we indicate it as dehydrated or there's an extracellular fluid overload. Base excess is to indicate hydration status. The common cause of metabolic acidosis are DKA, lactic acidosis, usually due to diarrhea because there's loss of bicarb, sepsis, renal problem. The causes of metabolic alkalosis can be caused by excessive vomiting due to loss of stomach acid and potassium, Cushing due to overproduction of bicarb. Respiratory acidosis can be caused by COPD, asthma, pneumonia, or respiratory failure. Respiratory alkalosis is due to hyperventilation, maybe because of anxiety, panic attack, etc. There's also mixed respiratory and metabolic acidosis. Usually the patient already death in line. There's a hypoperfusion and respiratory failure. Okay, let's look at the example of case number 1. 38-year-old male brought to ED at 6 p.m. complain of SOB. Symptoms has been persistent for the past 3 days. Upon examination, vital signs normal except for SpO2 of 90. So this SpO2 90 is an indication for us to do ABG. And lungs widespread bronchi. pH 7.3, CO2 53%, oxygen 65, bicarb 26, base excess -2. Okay, so this patient is in respiratory acidosis, hypoxemic. Alright, it is compensated respiratory acidosis. As you can count here, we need bicarb. Okay, how do we count it? 0.35 times 53, which is the carbon dioxide. So we got 18.55. See? Okay, so we need more than 18.55. So the bicarb here is 26. So the patient is in compensated state. So the diagnosis is compensated respiratory acidosis. This is question number 2. This is question number 3. Okay, this is question number 4. From question number 3 punya patient, who is the uncontrolled diabetic patient. She's a 30 years old lady, referred from KK for high glucometer. She forgot to take her insulin for the past 2 days. On examination, vital signs normal, GM33. So this is an indication for us to do ABG. Urine ketone positive, +1. Okay, pH 7.2, oxygen 75, carbon dioxide 40, bicarb 12, base excess -10. So this patient is in diabetic ketoacidosis state with decompensated metabolic acidosis. Why I said decompensated is because when we count the CO2, formula 1.5 times bicarb, which is 12, plus 8 plus minus 2, so we need 24 to 28, less than 24 to 28, and her carbon dioxide is 40. Okay, 40 is considered very high for this patient, so it is decompensated, even though by normal value is still within normal range, which is 34 to 45. However, when we use the formula, it is decompensated carbon dioxide. Okay, this is another case of decompensated metabolic acidosis. However, this patient is in sepsis, septic looking. Okay, case number 6 of case of compensated respiratory acidosis. She's a 65-year-old male with known case of COPD. Okay, complaining of breathlessness, with venturi mass. Okay, the PaO2 of 52, pH 7.25, carbon dioxide 67, bicarb 35, and expected bicarb, the formula is 0.35 times 67, so we got 23. Bicarb dia the 35, so the bicarb, even though in the range is high, however we consider it as compensated because we do need high bicarb of more than 23. So this patient is in a compensated respiratory acidosis. This is another case of DKA metabolic acidosis. Alright, this case I want to highlight on the anion gap. Okay, this patient has metabolic acidosis, anion gap of 24. Okay, it is a high anion gap. From the history, you can see he's a diabetic patient suffering from diarrhea and vomiting for 48 hours. So we are expecting him to be in ketosis. And from ABG, we know that he has acidosis, metabolic acidosis. So the anion gap is high. The probability of high anion gap cause is DKA. The question number 8, it is another very interesting case of respiratory alkalosis, which in this case is caused by the patient's anxiety, hyperventilation perhaps. Okay, he's in decompensated respiratory alkalosis. Right, the patient is 17-year-old male. He taken his father's car to impress his girlfriend. However, he had an accident with a bus. Okay, on examination, there's bruising, respiratory rate high of 24, pulse rate high of 110, BP borderline 120/85. Okay, the PO2 110, pH 7.53, PaCO2 23, bicarb 25. Okay, from here we know that he has respiratory alkalosis. However, from the bicarb looks okay, but when we calculate using the formula, bicarb equals to 0.5 times 25, we need 12.5 or less. So here the value of 25 bicarb is very high. So the patient is in decompensated respiratory alkalosis due to anxiety. Question number 9, this is a case of shock secondary to sepsis with metabolic acidosis, compensated. And the last one is quite interesting because this is a case of mixed respiratory and metabolic acidosis. And this patient, I assume already DIL.